طيب، بسم الله الرحمن الرحيم. الليلة عندنا محاضرة اللي هي بداية لأساس سلسلة محاضرات عن السايكوباثولوجي. معنا الدكتور نادر الزين. يعني هو تكرم علينا إن شاء الله إنه حيدينا سلسلة بتاعت المحاضرات في 4 محاضرات، ودي من المواضيع المهمة في السايكاتري. دي this is ABC في الآخر. يعني ما كل الناس حتى مثلا اليومين ديل they know psychopathology very well. الناس انت شوية بقت تعتمد على التشيك ليست بتاعت DSM ولا diagnostic criteria without knowing exactly how to assess the symptoms. And this is important. والموضوع ده افتكر المفروض غطى في 4 محاضرات. فدكتور نادر تفضل. واحنا افتكر باقي الناس تعمل ميوت عشان الليله يخلي بس دكتور نادر يقدم.
Okay, good evening. My name is Nadir Alzain. أنا استشاري طب نفسي. يمكن I might have met some of you, but for the majority, whilst I was in Sudan, I was working in Madani, a hospital by the name of Hassan Allop. Probably it wasn't known at the time, like in now, it is the equivalent of Al-Idrisi Hospital to the whole of Sudan, since Kober Hospital is no longer functioning. But I would like to begin by thanking our host, Dr. Yasir Mahjoub, for his generosity and hospitality to host these lectures. I'm very grateful that he asked for us to volunteer to give talks. Today will be the first day in a series of lectures about the subject of psychopathology. Today, I will give a background on the classification of psychiatric illnesses. Then the next topic or the next lecture, which will be on Saturday, I will be speaking about mainly the categories or the factors in the mental state examination, which will include appearance, behavior, or movement problems, and mood problems. The topic for the following, so that will be the third subject, will be on speech, thoughts, and perception. And for the last lecture, it will be on the subject of assessing cognitive dysfunction or eliciting cognitive function or disturbance in cognitive function. Does anyone know what is formal thought disorder? Are you familiar with the term formal thought disorder?
المحاضرة دي انتراكتيف، فالناس تفتح الميكروفون وتشارك.
Yes. The shortest poem in the English literature is made up of 2 words: Adam, 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 had them. Now, if I were to tell you that this is a poem in itself, when I first heard about it, I thought the person who made it up must have been suffering from some sort of mental health problem, or nearly so. But actually, the context of those words had other meanings. And this is what psychopathology is all about: finding meanings to certain symptoms of the mind and giving it interpretation. And then how do we group them together to give a meaningful diagnosis? And this takes us to the heart of what actually is psychiatry, as my Yasir had mentioned, that it is a subject that has been overlooked more recently, as opposed it was probably 40, 30, 40 years ago, before we had what is called the present state examination, which is what the predecessor for the SCAMS schedule for clinical assessment in neuropsychiatry, which is a structured interview for field surveys on mental illness. But it, doctors or psychiatrists were trying to find meanings. It is good and proper that we go through a checklist for symptoms in the DSM or the ICD-10. But what do those symptoms mean? What are those symptoms? Right? This is what psychopathology is about. Rightfully, we are more than just technicians who go through a checklist, right? We are supposed to be, as a consultant, at least as a consultant in psychiatry, you have to have the depth of knowledge to understand what these symptoms mean and why is it that this checklist that you have, let's say we have a checklist for schizophrenia, right? Why has the checklist now is somewhat different to a checklist of schizophrenia when Luhrer made his famous uh, 4 A's for affection, anhedonia, eulogia, and affect, right? Is that schizophrenia different to what we call now schizophrenia, right? Another example I would like to give is certain types of symptoms like catatonia or what we'll call Kolbum syndrome. If you've heard of the Kolbum, is a well-known German psychiatrist who came up with the term catatonia, right? Catatonia, as we probably all know, is a disturbance of motor movement. Uh, but Kolbum syndrome is disturbance in movement associated with echolalia. And I would like to ask all of you out there, how many of you have actually come across in the last 5 or 10 years for patients with catatonia? When I started out in psychiatry in the 90s, it was probably more common than what I actually am seeing now. I've rarely come across people with classical catatonia unless it was due to other physical cause rather than a psychiatric or a mental cause. Anyone could tell me when was the last time they had seen a patient with catatonia?
Yesterday.
Yesterday. Well, you've just blown out my theory out of the water. That is interesting. Interestingly, also when dealing with religious delusions, that is delusions that deal with religion, the last patient in the United Kingdom I saw with a religious belief or a delusion was in 2002. He believed that, or 2003, he believed that he was Jesus. Ever since we became the content of the delusions was mainly to do with what was online or conspiracy theories about things that happen in a digital world or an altered universe. But that was until I came back to Sudan. Do you mind sharing some of what the presentation was, Yasir, with your patients yesterday?
So the
Oh,
patient, when we talk about catatonia in its most classical form, اللي هي retarded form of catatonia with waxy flexibility, catalepsy,
yes.
posturing, mutism, these are classic. المشكلة إنه إحنا we focus on the classic and the rest are under-recognized. The patient that we saw was doing verbigeration. So when you talk to the patient, she would repeat words over and over in a meaningless way. Also,
Yes, yes.
she had an atypical presentation for echolalia. So when we ask her a question, we ask her, "Hey, do you have children?" So she would respond, was like, "Oh, do I have children? He's asking if I do have children," and then she will answer. And then you ask a different question. "Oh, you're asking if I am doing so." So she would repeat the same question in a different manner, but consistently in a meaningless way. So that was a combination of manneristic speech and echolalia. And then she was impulsive and was negativistic. When she was talking, like you ask her to do something, no, without a context, no to everything, no, 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 no. That was an example of negativism that she had. So these were the features. So we're not talking about the classic form of motor presentation. This was mainly behavioral.
But if I got it correct, that was actually what Carl Kolben had described. The catatonia or the Kolben syndrome was to do with catatonia and echolalia. And if I were to use the term, it was more of a psychogenic rather than a psychotic, or probably more of a neurosis than a psychosis, i.e., maybe it could have been simulated, or it could have been manufactured, or it could have been some unconscious manifestation of an internal problem rather than a pure psychotic catatonia that we tend to associate it with either severe depression or catatonic schizophrenia. But very interesting, very interesting. And what was the diagnosis for your patient?
She has bipolar disorder, and every time she comes to the hospital, it's either a manic episode or catatonia or combination of both.
Okay, well, very interesting. Well, the term itself, psychopathology, psych, as we all probably know, means the soul. Pathos means suffering. Logosology, which is another term for logos, means understanding or reasoning or finding out. So psychopathology is the science of, how would I have put it better than our Carl Jaspers, is the scientific exploration of the abnormal mental state. Carl Jaspers is a German psychiatrist at the turn of the 20th century, and his textbook, General Psychopathology, was a game changer in this field. It is readily available, and actually, most of what I'm going to talk about, I will send the papers, so you don't have to worry about reading or. Okay. You don't have to worry about writing what I am saying. I will send out the papers or treaties or research that has been done. And after each lecture, I would tend to do that. Now, what is the first time that the word psychopathology was used was by a German psychiatrist. Well, interestingly, at the turn of the 19th century, psychiatry was dominated by the French and following that German school, i.e., what is called the European School of Psychiatry. It was after the first and probably more prominently after the Second World War that this the field of psychiatry and psychopathology was taken over by the English-speaking school, i.e., in what I mean by that is in England or Britain and the United States. Probably the first attempt to classify mental illnesses was by by Hippocrates, and where he devised the humor theory of the temperament, that those with a hot temperament, that was to do with hot air, hence the term hot air. And then you had the phlegmatic, the choleric temperament, and that is to do with where the wind came from. But he had denied any notion that there was any maleficent being, i.e., being plagued by devils and so forth. But we move on to modern psychiatry, where probably the first psychiatrist to delve into the classification was the French psychiatrist Philippe Pinel, who wrote the two treatises on the subject. What the first was during probably at the end of the French Revolution, which was the philosophical classification of diseases, which had distinguished the various forms of psychosis. And then his second was the medico-philosophical treatise on mental alienation and mania in 1801. He was a proponent of the humane treatment for people with mental problems. Then that was followed by Jean-Étienne Esquirol in 1838, where he wrote his famous mental maladies treatise on insanity, where he came up with the 4 or probably 5 distinct mental disorders. Lithomania, which was another term for melancholy. Then he described monomania, which is probably nearer to delusional disorder. Then the term mania, which is a form of manic depressive or mixed form of mania. The term dementia, and also idiocy. It is of note that Esquirol was the first psychiatrist to bring the attention or to use the term intellectual disability, and came up with the terms idiocy and imbecility. Now we move on to that was the French school, and later we had Charcot and Janet, who looked into hysteria and believed that hysteria was of an organic cause. Prior to that, it was believed that hysteria had something to do with the woman's womb, and hence the term hysteria, as in hysterium, the womb of the lady. Yes, of course, we have to mention that even the term psychiatry was invented by or coined by Dr. Johann Christian Reil, who was a German psychiatrist, and this was in 1807. Okay. And then in Kraft-Ebing, who coined the term not melancholia. Melancholy was there. The term was known. It was meaning of depression, but he separated simple melancholy from psychotic melancholy. Then, as I mentioned, Karl Kalbum, who with the work of also with Ewald Hecker, came up with the terms, just one sec, the terms of dysthymia, cyclothymia, catatonia, hebephrenia, and paraphrenia, right? And did I mention that it was Hermann Ebbinghaus in 1887 that coined the term psychopathology? He was also the founder of child and adolescent psychiatry and wrote the chapter about mental disorders in childhood within the larger textbook of Handbook of Childhood Diseases. Okay. Then we move on to, as I had mentioned, Carl Jaspers, who had a very interesting background. He actually studied philosophy, similar to Janet, and then, as opposed to Janet studied philosophy, then became a psychiatrist. We had Jaspers, who was a doctor and practiced psychiatry. Then he moved into philosophy, and he had adopted what was called a Gestaltian form of philosophy, which stipulates that the sum is not is different from the parts put together, that we have to take the person as a whole experience, rather than consider the person a sum of very small parts, which is a very interesting concept around that time, very alien to the world at that time. We might actually consider it as normal when we look at the biopsychosocial model, or what is better called a holistic approach, rather than just looking at a medical perspective for an individual's problem. Okay. So, why? What is the main tasks of psychopathology? Well, I'm here going to quote the Task Force on Nosology and Psychopathology by the World Federation of Biological Psychiatry, and this came out in 2010. It was a joint statement, and it mentioned that the main tasks of psychopathology are: one, to record and describe experiential and behavioral abnormalities in their intersubjective context. So that is to record, describe certain, all abnormalities in behavior in the context of the person's subjective feeling or experience. Second, to explain their origin or subjective from a objective scientific perspective. So what are the origin this experience, and to attempt to understand the subjective perspective of the patient, and also to give an explanation as to how the patient feels about it. And this gives a rise to certain questions to do with the validity and reliability of our diagnostic classifications. To make it clearer, when we talk or diagnose someone with depression, if we were to rely only on the classifications, whether it's the ICD-10 and or the DSM-5 or ICD-11. I'm not disputing that you will find that the inter-rater reliability of all the diagnoses is very high. That as clinicians, we do understand or we do appreciate what the symptoms are. But the validity is actually diagnosing depression um, in Sudan, similar to diagnosing depression in the United States or in Europe. And to give an example, probably you've all heard of this, is to do with psychosomatic disorders. And it is also not for the symptoms, but also to do with the linguistic characteristic of presentations in the probably Western societies, if we have to consider Europe or United States or North America. It is the term depression or feeling low is a common verb. It is a common thing that people will describe such emotion. However, in our language, you very rarely would find someone coming up and saying, I am depressed or in the iktiab. More commonly, people in our culture equate feeling internal feelings and externalize them in form of physical symptoms. So if we will eventually, we do eventually have a system that guarantees that within the scientific community, i.e. for physicians, we do have a high concordance in our diagnosis, but is actually what we're diagnosing similar? So the validity from a patient's perspective, right? Is it very similar? But having said that, these the ICD-10 and the ICD and DSM are actually quite there is high validity, but it does not reach the 95% validity. I think in the majority or on average, they will probably around the 80 something. So there is about a small but significant proportion of patients that our diagnosis may not be valid. I'm not saying that they are not valid, but they may not be as valid as it should be. Okay. Okay. So, what are the types of psychopathology? Well, broadly, there are three types of psychopathology. That you have the descriptive psychopathology, which I will explain, and you have the clinical psychopathology, and you do have the theoretical psychopathology. So what is descriptive psychopathology? Descriptive psychopathology is to describe and denominate person's subjective experience and behavior in a way that allows objective communication about them. So it is to describe these certain phenomena. Some of them are observable, some of them are described by the patient. So I can observe catatonia, but I can not confidently observe depression unless it is a severe form of type of depression. So it is something that the patient expresses to you about them, right? So in descriptive psychopathology, you have to find means to describe and denominate the person's subjective experience. Now, two, as part of the descriptive psychopathology, it is to distinguish between normal and abnormal. Please, this is, I'm going to come and elaborate towards the end about normal and abnormal experiences and behavior, and to describe the nature and development of these symptoms. Now, there are two forms of them. There is a special form, which is the focus on the patient's self-experience and self-reports. And then we have the functional, which is the clinically defined, i.e. in that these aberrations or abnormalities are deviations from the standard deviations, which is the basis of what we use as the ICD or the DSM. So going back to descriptives, there are two main functions for descriptives. One is to describe the symptoms and objectively communicate about them between physicians and, well, different agencies involved. And second is to distinguish between what is normal and what is abnormal. Second, for clinical psychopathology, is to group significant symptoms into nosographical systems, i.e. syndromes or diagnostic entities. Now, what makes the diagnosis of, let's say we have someone with diagnosis of major depressive disorder, or for me, let's say, what is alcohol dependence syndrome? Now, because I'm specialize in substance misuse, so if you'd allow me to quote this, in alcohol dependence syndrome, there are 10 symptoms that criteria that needs to be satisfied, and within those 10, if you count, probably four or more, than the person does seem to have these problems. But who decides, or how is it decided that 3 or more? Why can't it be 5? Why can't it be less? Why can't it be more? And that is because we are using statistical models. These symptoms are aggregated together, and using certain high-powered systems, statistical models, that congregate these symptoms together, and then we have our diagnostic tools. And out of that came out the first tool that we had used as using questionnaires, or interviews, was the present state examination by Wing. Came out in the 60s. And if I'm not mistaken, it was actually the Department of Faculty of Medicine, Khartoum University, Department of Psychiatry. They have actually trialed the present state examination. That was in 1972. Can Professor Taha Bahshar and John Cooper, who led, and if I am not mistaken, it was John Cooper who went and visited Kosti. I met him, and he was one of my sponsors when I went to the UK. Anyhow, yes. So the second task or use of or function of psychopathology is a clinical function, and that is how to generate clinical syndromal entities. Now, please bear in mind that syndromes are a group of symptoms that occur together, right? Maybe that symptom on its own does not reach a threshold to constitute a diagnosis, but in the presence of other symptoms, right, it can reach the threshold to diagnose to reach a diagnosis. However, these symptoms do not necessarily have the same etiology, right? These symptoms occur together, and it is based on statistical modeling that it is decided that they satisfy a certain criteria to give a certain diagnosis. Last but not least is the theoretical psychopathology, which is the study, the etiology of pathogenesis and strongly link psychopathology neuroscience. So the last form of psychopathology is theoretical, or what is called experiential psychopathology. This is to look at the link, these group of symptoms, as I had just mentioned before in the clinical, when we look at them in a syndromal perspective, that these groups of symptoms, when they occur together, we give them a certain label. But in theoretical psychopathology, we look at these symptoms that we had labeled, let's say schizophrenia or alcohol dependence or depressive disorder or personality disorder. Do they have a shared or common symptom? Are they part of whether it's genetic, whether it's on a biochemical level or a genetic level? We don't know how to link that group of symptoms or symptom with a certain causation. Now, in the majority of medicine, we are taught about, we are given what is normal. When we studied medicine, when you go to medical school, in the first few years, you do your basic sciences, physiology, biochemistry, and whatnot. And then you learn about what is the functional basis of these disciplines. And it is in our clinical teaching, we go to what is called pathology. So we look at the aberration, but in psychiatry, we have not had that luxury. Can anyone tell me who decides? You may all have heard, and we will talk about it, probably not the next lecture, maybe the one after, when we talk about speech. Who decides the construct of what constitutes a normal speech? Before we decide what is abnormal, who decides what is normal? Anyone can answer this question, please? Can anyone attempt to answer the question? Hello? There are 28 people around. I couldn't get one single answer. Anyway, actually, those who decide what we as psychiatrists have probably what's called the upper hand. Yes, we can say what is abnormal, but how good are we in saying what is normal? And those are two different things, right? It is linguists it is philosophers who decide what is looks normal. And hence, you will find that the majority, if not all, of the psychopathologists are actually philosophically trained. It is my opinion, as Nadir and this is just my personal opinion, that in order to gain more depth and understanding of a human abnormal phenomena, we have to understand and appreciate what is uh, a normal human phenomena. It is my contention and view that the dualistic view that there is a separation between mind and body, uh, it is becoming less, there is less strength to that argument than, let's say, probably 100 years ago. I am the opinion that all um, mental function uh, functions in our higher mental functions, in our thinking, in our thoughts, in our speech, is a manifestation of functions of the central nervous system. As much as the muscles contract and give a certain functions, the functions of the heart, they pump out uh, oxygen and blood. It is the function of the brain to give the mind, and that is all what it is. My conversation to you is a function of my mind. It is not a function, but to understand that it is a function of my mind, I need to know what is a normal before I start to say that what I am saying is abnormal, and I have to accept that some of what I am saying to you may come as a bit of an abnormal, either in its context, or it may look different or abnormal in the way it is structured, which is when we look at speech, in my talk, well, speech, we talk about the rate, rhythm, tone, and who was it that decided that what is normal speech? I can tell you it was not a psychiatrist, or at least it was not from a psychiatric perspective. It was from a philosophical perspective that this was decided that um, this was speech. Last but not least, how can we look at psychopathology? Is we have what is called the 4Ds+1 theory. Given this was a theory made by T. Davis. 4Ds are deviance. So part of what constitutes abnormality is that it deviates. There is deviance. Deviance inherent in behavior, right? And to give you an example, or at least he gave the example of people with pedophilia, that pedophilic tendency, that probably 3 to 9% of males have this tendency. But how do we differentiate pedophilia as a disorder from pedophilia as a deviance? In that it causes people who have these, if it causes them distress, which is the second D, which is distress. I give you an example, like people with hypochondriasis. Hello, someone is having a birthday. Then we can look at dysfunction. Does the symptom or the disorder cause dysfunction? And to give you an example, like in major depressive disorder, how we differentiate in its severities, the level of dysfunction it may cause. The fourth one is danger, as to dangers to oneself and others. And I can give you an example, as in uh, um, substance misuse. Let's say methamphetamine. Methamphetamine causes harm to self and may cause the person harm to others. Or at least if we take the example of nicotine, smoking causes harm to self and harm to others. So the other last D is the duration. In how do we differentiate between acute psychotic episode is that the symptoms tend to disappear within a certain framework, but time frame. But if they were extended beyond that frame, let's say up to 6 months, then we would have to consider a diagnosis of schizophrenia. Or if we were to use the other analogy of the one that I had used, the use of methamphetamine, which caused similar symptoms to schizophrenia. If the delusions or the psychosis goes beyond a certain time frame, then we would have to consider that there is a different diagnosis. I'm going to stop here because I have babbling too much, and I will be sending you all relevant papers. I tend to, I will send you also copies of Fisher's Psychopathology and Sims Symptoms in the Mind. The reason I've titled these lectures are Symptoms in the Mind is based on Andrew Sims, who is was a late professor in psychiatry up in Leeds, who wrote a very beautiful textbook on psychopathology. So I will be sending all what I have talked about to you and I actually tend to rely more on papers rather than textbook, but it's always nice and reassuring to have a textbook. Sorry, I spoke too much, and the floor is yours, Yasir.
Thank you very much for this very wonderful, at the same time, like, detailed and concise at the same time lecture. Yeah, the floor is open for questions. Anybody who has a question, they can raise their hand. لحد ما الناس if anybody has an interesting question they can feel fine. أنا ممكن أنا have a question. Okay. Which is a question and also slash a comment, which is one of the criticism that psychiatry had for a long period of time. This was the reason why the DSM came, that we tend to medicalize emotions, and when to medicalize norm. A person who is sad, we call them depressed. A person who is anxious, we call this an anxiety disorder. وبعدين it extends to a lot of things that we see. We see a person who's angry, we tend to call this, we give them a label, we give them a diagnosis, intermittent explosive disorder being a good example for this. And that gets us to the point of the boundaries between normal and abnormal, or the norm as a reference.
I think this sums up what psychology is about now, what psychopathology is about, as to where is that thin line between what is normal and what is abnormal, right? Psychiatry as a discipline on its own cannot answer that question. If we were to undertake a medical model to say what is normal or what is abnormal, we can, as a psychiatrist, as a clinician, we can say what is abnormal, but our premise does not extend, we don't have the prerogative to say what is normal, because in part in our medical education, we have been focused on causative medicine. That is medicine that is explained by a causative agent. Psychiatry, we don't get proper psychiatric training. We don't let. It's only after after our graduation or our specialization, and there is less emphasis on what is normal, or how do we know what the difference is between. We know what is, so we have good sensitivity to what is abnormal, but we're not very specific in that. You see what I mean? Because in our, in you know, due to various factors, we do not get trained in what is normal. The first thing we are rushed into is going on a checklist of what is abnormal. So there is less so appreciation of what is normal. And to understand what is normal, it takes more depth. To come up with, let us to give an example of to, um, psychiatrists do not have do not retain the ownership of psychiatry. Well, psychiatrists do retain the ownership of psychiatry, but not of mental health. Mental health exceeds and goes beyond psychiatry. It goes. We have to look at different spectrums. One of the papers that I will going to be sending is that one, you might want to look at, we have two views or various views on what is a diagnostic criteria. We actually tend to use categorical system. So you have schizophrenia, you have depression, you have, so different categories. But actually, symptoms from a subjective experience are continuum, right? Even within the same person, the symptoms, certain symptoms might exceed others. They may, let us say, hallucinations and delusions. They wax and wane their course even within a certain presentation, for a specific presentation, but they wax and wane. Now, interestingly, it was Bleuler who, when he came up with the 4 A's, he gave a distinction between diseases that take a deteriorating course, that take a intermittent course, or what is called a wave-like. They wax and wane, but never deteriorates. The person retains their main characters. Probably what he was describing was a delusional disorder. But in our classifications, that continuum perspective, although as clinicians we adopt it, right? And the way we do so is by not having just a psychiatrist on board, but you have a team of multidisciplinary. So you have clinicians, other clinicians, nurses, psychologists, social workers, occupational therapists, and so forth. And probably I would have recommended having a philosopher. And that was it was one of the suggestions in the UK, is why not have a philosopher in mental health team. But irrespective of that, I think I agree with you. And probably it is only when and if we ever reach causative factors and causation in mental illnesses, then they will probably this discussion about what is normal, what is abnormal, will disappear if we can find the smoking gun. But we had attempt to do so with post-traumatic stress, which was the first diagnosis that had a causative agent, that there has to be a stress, certain stress, and then there's, but even that is not well, what is an abnormal reaction and what is a normal reaction? What is an abnormal reaction? So it is difficult.
I have one question, maybe two,
Yes.
if the time allows.
Please do.
First one is about the definition of delusion within our culture or within different cultural backgrounds. I mean, mainly if you refer to delusions of grandiosity in people who have strong religious beliefs, mainly within Muslims. How do you differentiate between these beliefs in the context of the cultural background and the actual delusional belief?
Thank you very much for that question. Thank you very much. Now, and thank you for no one asked me why did I give this talk completely in English, and apart from my name, I don't think I had mentioned any word in Arabic, because in defining the word, if you gave a good example, if we use the term delusion, when it had been translated in, I think it was in the 70s or 80s, to in Arabic, it's called dalalat. صح? The term dalalat has very significant connotations, and large part of it is in the has a religious meaning. And when we come to in my talk on speech, disturbance of speech, I will give you an understanding as to why, how these structures of talk and speech is actually based on philosophies that somewhat are alien or not as accepted or not as familiar in certain cultures. So if I were to tell, I personally had a problem in telling a patient that, or the family, that their son or daughter or father had dalalat, right? However, it has been agreed, it has been translated, it is used that the term delusion means dalalat. Even delusions. Now, when we talk about delusions, we will have to understand that delusion is, well, we commonly refer to it as erroneous beliefs or erroneous thoughts. But actually, what constitutes a normal thought? هي الفكرة الصحيحة, right? Now, in speech, there is certain ways that speech is structured. You will find also in that thoughts. Interestingly, Carl Jaspers was who the person brought the term form and content in terms of thought. We talk about thought form, formal thought disorder, and form content. Prior to Jaspers, there were two same things. There wasn't this delineation between them. But what constitutes a disturbance of thought? What is a normal thought form? That is not the prerogative mainly of psychiatrists. Right? Formal thought disorders, yes, it is doctors psychiatrists who decide that this doesn't look right. But who decides actually what is right? And when we say a delusion, it's a wrong thought. How do we know a thought is wrong? And I will talk about that in my next speech, in when we talk about thought and how, what is knowledge, what is a true knowledge, what is a valid knowledge. And if I were to give an example, then you can think about it until we talk about delusions, specifically in people with alcohol dependence, chronic alcohol dependence. You have delusions of infidelity, that the person's partner is having an affair. Have you heard of this, Victor? Victor,
Yes. Yes.
delusion, you're familiar with the term delusions of infidelity,
Yes. Yes.
right?
Uh,
Now, uh, that the person believes that his partner is having an affair. صح?
yes, and it's associated with
Okay.
more. Sometimes they use this term as well.
What if the partner does have an affair? Does that make the delusion? Can the person whose partner is having an affair not have delusions of infidelity? Did I explain it correct?
Yeah, yes, I think that's a very interesting question because in the context of his beliefs, if he has any evidence that his partner is having an affair, then that will not be a delusion. But if he's, I mean, it's just by chance he has partner is having an affair, and it happens that she or he is having, then this might be defined as a delusion. Although it is
So
fact, I think his beliefs is not based on any evidence. It's just based on in some
good.
morbid
And
thing.
what constitutes evidence or fact? Now, I am going deeper. I'm, I'm not trying to catch you out, but what constitutes uh, evidence or fact? Now, that is not, is that the prerogative of a psychiatrist؟ يعني ده هل ده المجال بتاع الطبيب النفسي انه يمشي يحقق كويس؟ But there are certain criteria that have to, that as a psychiatrist, I have to have at the back of my mind to understand, to evaluate what constitutes and understand what constitutes a normal thought process, right? So even the person, if they reach, and a person who reaches a wrong conclusion can actually, doesn't necessarily mean that they have a delusion, right? Even if they have a false idea or a false belief, it doesn't necessarily mean that they are having a delusion. You agree with that?
Yeah, absolutely, yes.
But what I'm trying to say is that um, we have to ensure that our doctors, our trainees have enough training and breadth and depth in their training, not to understand just what is normal, but also what is abnormal, but also what is abnormal. And hence, the reason why I have decided to give this talk on the my first lecture on the history is to look at where it all started, right? And how it has progressed. So as trainees, you can see the progress of thoughts and thinking of psychiatrists as to what constitutes a psychiatric symptom and why, if it has changed, why has it changed throughout, how we ended up having the DSM-5, the ICD-11, right? Now, why the DSM-4, why have we had, if we are saying this is what schizophrenia is, then why did we have to have DSM-5? Why could we not have just stopped at DSM-3 or 4? Right? Why was there a need to change? I'm not saying why. I would like my trainee, the juniors, those who are seeing, is to think about why is there this change? Why has this change come from? Part of it is actually because, as I had mentioned, one of the parameters of psychopathology is giving clinical psychopathology is coming up with diagnostic entities, but that is based on statistical models. So as we improve our statistical models, it's likely that we will have to change our diagnostic entities. Wouldn't you agree? Sorry?
Is a question
Hello?
to the or to specifically to
Anyone can answer it. What I'm saying is that we come up with these uh, um, diagnostic entities, not just because of us psychiatrists, but this is based on statistical models. And as statistical models change, there is a need to change our diagnostic entities. Yani, if you agree to that.
I agree. يعني الموضوع this was a very good example with autism spectrum disorder. حتى the dimensions and domains of psychopathology they had moving from a 3-domain system to 2-domain system between the DSM-4, DSM-4 and DSM-5, with ICD-10 and ICD-11. This was very obvious, and the change behind the process, they found like it was more like it provides the similar يعني specificity and sensitivity, yet while using the 2-domain. And there's no difference, for example, between communication and and I think it was not far. I think it's communication and connectivity. I think.
And it's likely that in the next foreseeable future, when these trainees become consultants, that we be facing new changes more frequent, particularly if we involve AI, who will be coming up with new diagnostic or statistical models very frequently. And these models, the ICD-10 or the ICD and the DSM does not just affect us as psychiatrists. It also affects healthcare systems, insurance companies. It goes beyond just clinicians, right? It involves also the patients, right? We cannot divorce ourselves from the impact of patients and patients' groups and their influence on the DSM. However much we would like to say that it is developed, it is very clinical, and yes, but there's an underlying philosophical underpinning all of this, and as long as there is a debate as to what is right and what is wrong, right, and we have to improve, we have to evolve. I think we have to accept change. And actually, I think moving from DSM-4 to the DSM-5 is a overall healthy attitude. Because if something is static, then it either means that it's either not doing what it's supposed to do, or that it's no longer relevant. If something cannot be changed, then it's unfortunately going to expire. Or at least things did, yeah. Okay, yeah. Any other question?
All right, I don't think we have more questions. And I will end the recording. Munira?
الو
أي. أنا بستند مرات الكرايتيريا المخطوطة في الدي اس ام أو في الاي سي دي 10 مرات ممكن نشخص الحاجة يعني من غير الكرايتيريا، يعني مثلا يجيني سكيزوفرينيا وما بتنطبق عليه الكرايتيريا،
نعم.
فأنا بس دار من الحتة دي.
والله هي شوف، احنا ما تكنيشنز كويس، يعني احنا اطباء، احنا بنخط الكرايتيريا كويس. احنا نفهم يعني التكنيشن ده بده حاجه كويس، انه يلمها مع بعض كويس. ما ضروري يفهم الباك جراوند بتاعت الحاجه، يعني انها كيف نشأت وكده. انا I would hope كويس، يعني اتليست ده فهمي الخاص بي، وده ما بلزم به الناس تاني. انا افهم انه دي ليه احنا بنقول ده سكيزوفرينيا كويس. يعني هل عشان عنده ديلوجن وعنده هلوسينيشن؟ طيب ايه هي الديلوجن؟ ومنو القرر الديلوجن دي ديلوجن؟ يعني طيب منو القرر انه دي ما ديلوجن؟ خليك من انه دي ديلوجن. احنا ليه كويس يعني بنقول الديلوجن دي فكرة، طريقة تفكير غير سليم، فيها عطب، فيها منو اللي بيقرر انه التفكير السليم هو شنو كويس. زي الهلوسينيشن، انه الهلوسينيشن هي الحواس كويس. طيب منو اللي بيقرر انه الحواس الصح بتشتغل هي شنو كويس. زي ما مثلا انه اللي بيقرر ال- اللوحة دي جميلة ولا ما جميلة كويس. انا قدامي تحفة، انا بقرر انها جميلة ولا في حد تاني يعني كويس. ليه دي عندها اساس جمالي وما يعني لازم انا كطبيب نفسي افهم ال ال مش بس البيولوجيكال ولا السايكولوجيكال ولا السوشيال، لازم افهم كمان الفيلوسوفيكال اندربيننج بتاعت انه الحاجه دي انت بتقول لي دي ده الطبيعي. خليك من انها ما المرضي. انا داير اعرف الطبيعي. ما احنا هسه في الفيزيولوجي والبايوكيمستري والاناتومي بندرس الطبيعي قبل ما نمشي في رابعه وخامسه وسادسه ندرس الديزيزز وكده كويس. ليه في احنا في السايكاتري انا لازم ندرس الطبيعي. اذا قدرت اوصل فكرتي صح يعني كويس. ليه احنا ما بندرس ايه هو الشيء الطبيعي كويس عشان بعد ذاك انه اقرر. انا ما بقول انا انه فعلا الدي اس ام لما يقول لك سيرتن كرايتيريا لانه دي سكيزوفرينيا، انا مش في انه فكرتي آه انه دي سكيزوفرينيا. ولما تبقى اي واحد في العنبر حيعرف السكيزوفرينيا شنو، المرضى بيعرفوا السكيزوفرينيا كويس. لكن انا كاستشاري لو بعرف انه وات از نورمال من الاب نورمال اقدر اقرر من اول خطتي. انا عارف انه البروجنوز بتاعت الشخص ده كيف كويس. يعني كانك تعرف السكيزوفرينيا ان ادوك تشيك ليست مع دي، يعني معلش الكلمه تكنيشن يعني بيعرفها انه يمرر تيك بوكس اي كويس. ولو انه تيك بوكس هي حتى بتاعت لو بتعرفوا السي دي كومبوزيت انترناشونال فور دايجنوستيك انترفيو، ده كيف انك تشخص using الاي سي دي والسكيد schedule for clinical interview in diagnostics. ده ان دي اس ام، ده كيف تشخص using الدي اس ام كويس. ده ديل structured interviews حاجات ضخمة جدا، ما وإنه لازم تاخذ تدريب إنه what constitutes a symptom. كويس، ما بمروا بتشيك بوك كده إنك تعين لهم تك تك تك، لا، الانترفيو نفسها كيف تسأل السؤال عشان تلقى الإجابة. كويس، فهي ما فكرة إنك والله عنده سيمتوم، كويس، أنا أقول لك جمع لي ديل 3 سيمتوم هنا و2 سيمتوم بجاي اديني 5، يعني ما قاعد، ما بنبيع السيمتومز ونشتري، لا. السكيدجول لو فيكم اشتغلوا ريسيرش ان شاء الله هتعرفوا السكيدجول ده كبير. الستراكشر انترفيوز للفيلد اسسمنتس، كويس، حاجه ضخمه جدا يعني، ودار له تدريب كم الاسكان ده، احنا قعدنا تقريبا اسبوع كامل بنتدرب كيف انك تعمل انترفيو. نستعمل السكيدجول فور كلينيك اسسمنت ان نيوروسايكايتري، اللي هو كان ده الحفيد البرايم present state examination. how to ask the questions, how to يعني interpret the results كده. ما القصة بتاعت عندي 3 سيمتوم من هنا أنا أطلع كويس. بعدين في حاجات they overlap يعني، وفعلا اتزنقوا فيها زي السكيزو افكتيف ديسوردر. كويس، يعني الدبريشن amongst people patients with schizophrenia I think كم يا 40 يا 60%. هل دول كلهم هنقول انهم سكيزوافكتيف؟ كويس، ف I think انك for the colleagues you have to think deep about what constitutes normal. كويس، how to understand what is normal before انك تمشي لل abnormal. كويس، ان شاء الله اكون جاوبت على سؤالك يا دكتورة.
شكرا شكرا يا بوس.
اي
طيب.
سؤال تاني؟
أنا حقفل التسجيل.